Dr. Durand. Thank you so much for joining us today.
Hi, it's great to join you. Thank you so much for having me.
Thank you. So, Dr. Nancy Durand is an associate professor in the Department of Obstetrics and Gynaecology at the University of Toronto. A recognized global leader in preventative health and vaccines, Dr. Durand has presented extensively at international conferences, including the International Papillomavirus Society Conference. Her work is dedicated to advancing efforts to eliminate HPV-related diseases and cancers. So, thank you again, Dr. Durand. And I think to start things off, my first question to you would be, what do you see as the role of OB-GYNs in the prevention and management of HPV-related diseases?
Well, I want to first start with the role of OBGYN as a specialty in general. Our specialty of obstetrics and gynecology is focused really on the care of women throughout their lifespan. And we know that HPV can affect and potentially cause disease in women and their partners from the onset of sexual activity and then for several decades of life. In general, I'd say in Canada, prevention and screening for HPV related diseases is provided by our primary care providers. And then once detected, people with disease are then often referred on to the specialist, like myself, the obstetrician gynecologist, for management and treatment. However, a majority of our specialty also must be to educate ourselves, primary care providers, and the general public on both the diseases that HPV can cause and the ways that we can prevent them. And how has my role sort of developed over the years in obstetrics and gynecology as a specialty? Well, my clinical practice over the last 30 plus years has definitely evolved from where I started. So initially, my role was more in cervical screening and detection and treatment of HPV related diseases, especially in colposcopy. But then, when HPV vaccines were first licensed and launched in Canada, which was back in 2006, believe it or not, that's 18 years ago this year, my personal interest then shifted to encompass and include prevention through vaccination, in addition to prevention from screening and treatment of HPV related diseases.
Definitely. And I think it's so important to recognize that different specialties are involved in different aspects of treating and preventing HPV related diseases as well. And I think there's so much education that we can share with our patients. I think a lot of patients don't realize, for instance, that HPV with pregnant women, for instance, doesn't affect just the mother, and that, HPV infection can increase the risk of so many different pregnancy complications, ranging from spontaneous abortions to intrauterine growth restriction. There's so much that I think the general public doesn't know too much about that is an opportunity for education.
True.
And another question that I had was, in Canada, cervical cancer has been increasing at a very alarming rate of about 3.7% per year since 2015, and is now rising faster than any other cancer in both females and males in our country. So I'm wondering, what weaknesses do you see in our current screening, vaccination, or patient education strategies, and what can we do to improve the situation?
Okay, so let's start with weaknesses in our HPV vaccination strategies. We need to identify who we are not reaching and why are we not reaching them. So in Canada, we're lucky to have school-based HPV vaccination programs right across the country, which is really great. But we know that vaccine coverage rates in these programs is not optimal. In fact, it's actually poor in many of the most populated provinces like Ontario. We have less than 50% vaccine uptake in our grade 7 program last school year, 2023, 2022, here in Ontario, where I live. So we need to really examine things like the demographics, meaning the age of people that we're vaccinating, the geographic location, and those issues surrounding parental consent are extremely important. Why are parents not consenting? We also need to really tackle a lack of knowledge of HPV vaccination in the general population. Adult vaccination is not well known. by the general public. And we have, in fact, no upper age limit by the National Advisory Committee on Immunization here in Canada. And also, more than 50 countries globally have no upper age limits. So many people are not aware of that in Canada. And many are also not aware that males can benefit from HPV vaccination for the prevention of anal precancers and cancers, for the prevention of oropharyngeal cancers, cancers at the back of the mouth and throat. And we know, for example, that oropharyngeal cancer in males is 4 to 5 times more common than it is in females. So that's something we really need to target. Now, what next about the weaknesses in our current screening strategies? Well, we only reach about 60% of the eligible female population with our cervical screening programs in Canada. So that means, conversely, about 40% of eligible women are not being screened. And similar to our thinking as for vaccination, we again really need to think about who is not being screened and why. So first, with who is the demographic nature of those people, the cultural barriers perhaps. And we also need to make every effort to reach those who are at highest risk for disease, including victims of sexual assault, transgender people, people living with HIV. Thirdly, we have weaknesses in our patient education strategies. So we really don't have education targeting adults who may now or may in the future become parents. And we know that if adults understand the value of HPV vaccination and cervical screening, they're going to be more likely also to consent their children to be vaccinated in the school-based program. It makes sense that if we reach the parents, we will also indirectly reach the children and improve our vaccination rates. We certainly have knowledge gaps about HPV and prevention within all our healthcare providers, not just physicians, but nurses who work in clinics, nurse practitioners, midwives, pharmacists, dental professionals. Dentists and dental hygienists are often those who examine us twice a year and look in our throat and can often detect oropharyngeal cancers. And we shouldn't forget about other health practitioners that the patient may be seeing. So naturopaths, homeopaths, all of these groups of individuals need to be included. Those of us who work in the teaching setting must remember that not just the attending staff, the nursing staff, but the trainees also need to be educated on the value of prevention through both vaccination and screening. And I've even learned in the office and in the hospital clinic that our support staff, even like receptionists, need to be included. It's like a team approach so that we're all really on the same page. So how might we address some of these issues to help us improve outcomes? Well, one issue that has been proposed back in about 2018 is the concept called HPV Faster. So this is the idea that we link cervical screening opportunities of women with the offer to vaccinate them at the same time. And as we are starting to move across Canada to cervical screening by HPV testing, it's natural that the awareness and the opportunity to discuss prevention through HPV vaccination will become easier. Those opportunities are going to present themselves more frequently. Instead of just doing a PAP, like in the past, we are now saying we are testing you for the detection of high-risk types of HPV that can increase your risk for HPV-related cancers. And if you're not yet vaccinated, you can still be vaccinated to reduce your future risk of these diseases, as can your partner.
And definitely, and adding on to the part about HPV screening and self-sampling, I'm wondering, it's interesting because in Canada, British Columbia, certain regions of British Columbia now enables patients to choose between HPV self-sampling versus clinician collection. So I'm curious what your opinion on this is, and what direction you see sampling strategies progressing in the rest of Canada in the future.
Well, you're right. British Columbia and other provinces are starting to look at this idea of self-sampling strategies. And really globally, the trend has been increasing to consider either a component of self-sampling within the program or even move to exclusively self-sampling within a country. Now, this has been done in Stockholm region of Sweden for the past few years, since 2021. where they would mail out a self-sampling kit to all of those eligible. And in just the first year in Stockholm, the participation for cervical screening increased by 10%, from
Wow.
54% to over 60%. And much of this increase in screening by offering self-sampling was seen in people who were previously not attending cervical screening visits. So those are exactly the people who we really want to target. So that pilot program in this one region of Sweden has now extended to the whole country of Sweden. And now they are moving to exclusively offering self-sampling as their first line of screening. So to go back again, the option of self-sampling for cervical screening could be two different ways. It could be an opt-in approach, as in British Columbia, where if you're a patient in British Columbia, you can request a kit, but you have to request it
Right.
to get into that system. An opt-out approach is more like what I'm talking about in Stockholm, where all eligible people with a cervix are mailed a self-sampling kit. Or you could do also all those non-attenders, those who have not been screened ever or more than 5 years ago, could be mailed the self-sampling kit automatically. Sort of similar to how we send out invitations for breast screening, cervical screening, and colon screening currently. Now, here in Canada, it's a little more difficult, a little more challenging because healthcare is delivered provincially or territorially. So each region has to decide what is best within their context. So in Ontario, for example, where I live, Ontario's decided not to include a self-sampling strategy with its transition next year, 2025, to primary HPV testing with an mRNA HPV test. Regions that do opt to include self-sampling, you have to remember, they also have to have a method in place for those people who don't have a primary care provider to receive results and follow up. So British Columbia is interesting in that it's provided that type of individual who don't have any primary care provider with a way to connect with those who are volunteering as primary care providers and have agreed to manage these results, the follow-up and the referrals where needed. So overall, the benefits of self-sampling is that we do improve the overall participation in our cervical screening programs, and that we can reach those groups who have never been screened or seldom screened. We can reach marginalized communities. And we can, for example, reach those victims of sexual assault, transgender people who may be hesitant to do traditional provider cervical screening.
Definitely. And I think it's so important to keep in mind that people have different preferences for what they feel comfortable with, and not everybody is going to be comfortable with physicians collecting samples and doing screening. So I think having this option where patients have a choice in their healthcare, I think that's very important, and
Agreed.
definitely very important. I haven't previously thought about the follow-up on these results for patients who don't have a primary care provider. So it's very interesting to hear that there are physicians who are volunteering to step up into these roles. It's very
Exactly.
definitely. And we've already chatted so much, and you've shared so many great advice with our listeners today. And I'm wondering if there is one clinical pearl out of everything that we chatted about today, what clinical pearls or two would related to HPV care would you like to share with the listeners today?
Should not risk stratify to decide who to counsel about HPV vaccination or cervical screening. We should not exclude people for vaccination based on their age, based on their gender, or based on a past or current history of HPV infection or disease. It's in fact never too late to benefit from vaccination for HPV. And really, we need to believe as providers in the difference that prevention can make, both primary prevention through vaccination and secondary prevention through screening, especially primary HPV testing. And I really challenge people to think about that they believe in the difference that they can make. And it's really a call to action. For example, set an example yourself. Have you been vaccinated? Has your partner been vaccinated? Have your children been vaccinated?
Definitely sharing that message, so important. Thank you so much, Dr. Durand.
Thank you so much, Jen.